I am Mary Lloyd Ireland, and on behalf of my co-authors Matthew Blake, Orthopedic Sports Medicine Fellow at the University of Kentucky, and Benjamin Wilson, Orthopedic Resident at the University of Kentucky, I would like to present this part of the female athlete chapter on anterior cruciate ligament injuries. Dr. Edie Griffin asked us to participate in the revision of DeLee and Drez's Orthopedic Sports Medicine Principles and Practice 5th edition. Injury rates in female athletes continue at a very disproportionately high rate, 1 to 3 per 10,000 athletic exposures in females, 2 to 6 times the rate seen in males. Most of these injuries in female athletes are non-contact, occurring during pivoting, cutting, changing direction, landing from a jump. The risk factors can be classified as modifiable or non-modifiable. Fortunately, in think tanks and previous research, most of these factors are felt to be modifiable. The categories can be anatomic, hormonal, environmental, and biomechanical in classification. The risk factors that are anatomic, that are definitely associated, are quadriceps angle, knee valgus, forefoot pronation that is increased, may be associated BMI, not definitely associated femoral notch indices, a small notch indicating a small ligament, probably not sex dependent, ligament geometry, and tibial slope. More work will be done in these areas in research. Hormonal factors may be associated, the sex hormone effect on knee ligament laxity. However, there is no evidence to recommend activity modifications or restriction with respect to the phase of the menstrual cycle to prevent ACL injury in female athletes. Environmental factors are basically the friction between the shoe and the surface. Harder ground results in high evaporation, and low rainfall may increase the shoe traction interface. Increasing the shoe surface coefficient may increase risk of injury and alter movements, such as a rubber surface in a shoe or changes in the shoe surfaces. We must make sure that the shoe is designed for the surface that the high-risk non-contact injuries occur in, such as stop, cut, change direction in basketball, tartan floor, and other rubber surfaces increase risk of injury. These are modifiable. Biomechanically, neuromuscular factors are the most critical difference between men and women and are modifiable. Kinetic chain is influenced by motion of the trunk, core, hips, and ankle. Fatigue is a factor. Decreased quad stiffness and strength and decreased knee stiffness is a factor for increased ACL injury in females. Quadriceps dominant activation patterns in females. Imbalances in strength, flexibility, and coordination are also biomechanical factors. The most important biomechanical factor is observing the mechanism of injury, and this also leads us to what we do with prevention programs. 2 different landing patterns. If we land in a position of safety with the hips and knees more flexed, such as in a tennis get-ready position, we're less likely to have an ACL tear. This diagram shows the position of no return and landing when she's rebounding in basketball. So the ACL has torn probably by the 3rd column. Awkward landing, non-contact, body going toward the injured leg, momentum of the body going forward at the trunk. This position of safety, as shown on the left, can be thought of as the position of the hips and knees and foot and how well the muscles can then work in a good muscle, bad muscle, or agonist, antagonist, such that the position of safety, the body alignment from the back, normal lordosis, hips are flexed more, knees are flexed more, so the hamstrings are at a more mechanical advantage to prevent anterior tibial translation. Tibial rotation is neutral, landing on both feet with balance all the way down. In this position of no return, where the ACL is at risk, the body alignment is basically rotated and off. The trunk is forward flexed, rotated to the opposite side. Hip is less flexed in adduction, internal rotation. Knee is less flexed. The tibia is an external rotation, and landing on one foot out of control, and an ACL injury occurs very quickly in 70 milliseconds. So the position of no return, where does the ACL really tear? It really tears probably before the column on the far right, where it looks ugly. We don't see patellar dislocations or MCL injuries occur with these mechanisms, so it is really a functional pivot shift that occurs, and that's the landing that we would like to see, a safe landing pattern, as opposed to this way the ACL gets torn. We'll show a couple of mechanisms of ACL injuries, non-contact, one in basketball and the other in trampoline, and you'll see differences in landing pattern and get a feel for how these injuries occur so quickly, unexpectedly. This University of Connecticut athlete lands out of her cone of stability with her foot way out. There is no way that her ACL will survive in this landing pattern. So this is a position of no return. If she would land within her cone of stability, more with her hip, knee, and foot underneath her trunk, this potentially could have been prevented. Oftentimes the basketball injuries occur with the individual in the paint trying to rebound, think about other things other than landing correctly, think about not going out of bounds. This individual jumping on the trampoline, wouldn't call her an athlete, but the one on the right's doing pretty well. But look at how she's paying attention maybe to the other person, and she just tears her ACL, mouth open. And the heart attack of the knee, so to speak, is that an individual grabs their ACL, knee to chest, which is the way that they reduce their anterior lateral tibial plateau subluxation by going knee to chest in flexion, and then the knee reduces. So what can we look at in our athletes to see if they have good control or bad control? These are normal individuals. The male is shown on the left and the female on the right. If we look at them from the front, you can see doing mini squat maneuvers. The male exhibits good hip over knee over ankle position, whereas the female, who's instructed just to do a single mini squat, is noted to have contralateral drop of her pelvis. Hip is internally rotated and adducted, which drives the knee into valgus. And to stay upright, the tibia ends up going into external rotation and the foot pronated. Seen more on the sagittal or side view on the right, the male demonstrates flat back and neutral pelvis rotation, while the female, again, normally just instructed to do a mini squat, has excessive lumbar lordosis and anterior pelvic tilt, again driving her lower extremity into a potential ACL position of no return. We have developed the Kentucky step-down test, which basically is shown here from the front and the side. Again, a normal individual. Her foot will have to hit that scale, and we will look at the quality of her movements over a 60-second period. Brian Noren, who is a PhD PT researcher I've worked with, has been instrumental in working with Gait and doing research projects such as this, and will describe the normal Kentucky step-down test and how to do this.
When the single leg step down test is performed, the individual starts from the top of the step, steps down, touches the scale with his or her heel less than 10% of their body weight, and steps back up again. A step down and step up is counted when the person makes it all the way down and all the way up, maintaining less than 10% on the scale, and returns all the way back up again. This is performed for 60 seconds. And the subject is encouraged to perform as many repetitions as they can during that period of time.
In this incorrect single leg step down, as you observe her trunk, there's ipsilateral to the same side, hip internal rotation adduction, which drives the knee into a wobbling position, valgus. And as she continues to try to remain upright, you can see the valgus at her knee. Tibia is in external rotation and the foot pronates. Her goal is to stay upright. Now, if you think about control, that 10% or less weight on her heel, she may slap down quickly and lose control, putting more weight. So they have to be in good control, and this would be a failed test. She'd do this for 60 seconds. Us orthopedists oftentimes clear athletes to play based on range of motion of the knee, tone of the quadriceps, watching them walk and jump, and a stable knee. This individual was cleared to play because passed all clinical tests, but when we put her in the gait lab, it's pretty shocking what we see. So this is the analysis of her gait, both from the sagittal and coronal planes. This patient is 10 months after right ACL reconstruction. We see a difference in the involved versus the non-involved side. Pelvis is forward, body is forward, and then when we go look at her from the back, you can see she has a dynamic Trendelenburg. She has less knee flexion and less hip flexion. When she lands on her normal side, hemipelvis pretty equal, normal pretty equal. Landing on her right side, you can see the drop in her pelvis or a dynamic Trendelenburg, weakness of her abductors, external rotators. ACL prevention programs are out there. They do work. It is difficult in a basic research scientific way to prove why they're working, since we don't really know the reasons for ACL failure. We know the categories, but we don't know the specific reasons, so what are we changing with prevention programs? They work. I think they do teach athletes better movement patterns and how to land in a safe position and avoid the position of no return. These programs should be sport-specific, and I do think they should be implemented and done throughout the season. You need to get coaches, athletic trainers on board to implement these programs in hopes of reducing ACL tears. Rates. What do these programs do? They decrease landing forces, decrease dynamic knee valgus, decrease varus and valgus movements of the lower extremity. They increase muscular activation, and they do have improved movement patterns. So it's like rebooting your computer, knowing how to move with certain better agilities, better foot movement patterns. So these patterns are important, and these programs are important to implement, but we should say these programs are to improve performance and not to reduce ACL injury rates, because you can go in saying, I'm going to prevent all ACL injuries and have one right away. So some ACL injury do certainly occur and may not be impacted by these programs. So tell the coach that it will improve their vertical jump, improve their movement patterns, but don't bill it as a prevention program. Thank you very much.